Welcome to the webinar on the administration and scoring for the Spinal Cord Independence Measure, the SCIM III. My name is Gwen Deswanko. I'm an occupational therapist and national clinical liaison with Praxis Spinal Cord Institute. And I'm here today with my co-presenter, Jessica Parsons. She's an RN and a national clinical liaison with Praxis as well. So the SCIM is designed to be used without any formal training, but we've created this webinar as a resource, and it's designed to provide further clarification to support scoring and administration of the SCIM in the context of the Canadian healthcare system. So this resource will also provide some guidance for the use of national SCIM data from the National RHSCIR database to support program development at the clinical level and research to impact change. So today we want to talk a little bit about Praxis Spinal Cord Institute, so who we are and what we do and how Praxis can support your clinical team. We want to provide information on SCIM as best practice implementation, so why this outcome measure was chosen, how to use the outcome measure and access resources. Spend some time looking at different case studies, which will help guide some of that scoring as well. And then we've saved some time at the end to discuss the value of the SCIM data collection, looking at what those reports will look like for the facility, and then how to use the SCIM data locally and nationally to support clinical change. So about Praxis Spinal Cord Institute. This was formerly known as the Rick Hansen Institute. And this name change is significant for Praxis as moving research into action. So Praxis is a Canadian-based not-for-profit organization that leads collaboration in spinal cord injury, research, innovation, and care. And the goal of Praxis is to identify, develop, validate, and accelerate the translation of evidence and best practice to reduce incidence and severity of paralysis after spinal cord injury, looking to improve healthcare outcomes, reduce long-term costs, and overall improve the quality of life for those living with spinal cord injury. So Praxis has 4 program objectives. So looking at the consumer engagement program, this was really meant as to increase opportunities for leadership and partnership for people with lived experience in the areas of healthcare, research, and industry. And looking at the commercialization program, this was meant to increase access and development of spinal cord injury related innovations. Our CURE program looks to increase understanding of biology and physiology of SCI to develop promising new therapies. And the CARE program focuses on evidence-informed care to guide best practice. And that's what we're looking at today is best practice. So implementing for the functional assessment and rehabilitation. And this is specifically the Spinal Cord Independence Measure. And this one is really important because we all have this understanding that accurate clinical outcome measures are essential to monitor and track function in order to determine treatment goals and measure progress after injury. So as mentioned previously, accurate clinical outcome measures are essential to monitoring and tracking functional progress and improvements in people with SCI. And the SCIM was chosen specifically for this population. It was developed in 2007, and it's been sensitive enough to detect changes over time. This has become the recommended tool to assess function in the SCI rehab accreditation standards. It has high clinical relevance for the rehab for individuals with traumatic or non-traumatic and with complete or incomplete spinal cord injury. The SCIM is also a frequently used research tool for assessing response to treatment in individuals with spinal cord injury. And we look specifically to assess the ability of SCI clients to perform basic activities of daily living, self-care, respiration and sphincter management, and mobility. So most importantly, this tool is important for collecting information. So it shows to have excellent reliability and validity, excellent responsiveness. It's 26% more sensitive to change compared to the FIM in the SCI population. No established norms, but it does show a floor effect for higher lesions. and a ceiling effect is observed for T1 to T12 for self-care, respiratory and sphincter, and management scales. So looking at the data that's collected, it really gives really valuable information about where your patient is when they're first admitted to your facility, as well as information when you're getting ready for discharge. So it gives you information very detailed on transfers. So pivot transfers, sliding board transfers, are they looking at using a ceiling lift on admission or at discharge? It gives you information specifically around mobility and ambulation, eating and drinking, what kind of tools that they need set up, or is there total support that they're looking at, information about respiration, bowel management, level of assistance that they're using or equipment that they need, and looking again at bladder management as well. And how can SCIM inform our clinical practice? So we have the data that we collect, and it can be used at the clinical level for goal setting, tracking progress, patient education. It can be used at the program level. The data can be reviewed by your facility, looking at resource management, equipment needs, and evaluate effectiveness of a treatment program. And it can also be used as a metric, so reporting to administration, possibly looking at what your staffing levels are like or care needs for your patients. And then there's also the research part that we can look at. There's a large pool of data that is collected through a national registry, such as the RHSCIR, and we'll talk about that one just a little bit later on. But this collection of data alongside other facilities gives us that further comparison, so assessment and evaluation of the effectiveness of a treatment or intervention. So this is just a visual to show where we are today and where we would like to be in the future. We have SCIM data that's been collected and supported since 2014 with 10 facilities across Canada. It's collected in the RHSCIR data pool. And it gives us the opportunity to use the data in a meaningful way to inform clinical practice. So move from interesting to actionable information through analysis and interpretation. So looking specifically about administering the SCIM, and again, just important to remember, this is a tool to collect data for our clinical use. It's not just for research purposes, but this is appropriate for all of our adult SCI clients who are admitted to a rehab facility. This incorporates best practice, it aids in sustainability of the practice, and it tracks functional change over time. So the scoring and administration part of SCIM, it is really a team effort. So sections can be divided between nursing, OT, and PT. It's recommended to be completed within 72 hours of admission and discharge, but it can be completed more frequently if this information is valuable for decision-making, goal setting, discussions with patients. It usually takes 30 to 45 minutes if done formally, but what we've found is that it can be done in more of informal clinical settings, discussions with teammates, and it can be done, started and stopped whenever it needs to be done. There's no equipment that's used. And the scoring is for the 19 items. So they're divided into 3 subscales: self-care, respiration, and bowel and bladder, and mobility. And the items are scored based on the activity that the client performs during regular daily activities at the time of the assessment. So we're trying to capture what a patient is typically capable of doing. And each section has a total score, with a total score between 0 and 100. Higher scores reflect greater independence without equipment or assistance. So things to keep in mind: scoring is based on the patient's baseline function that is consistent in multiple settings. So the score should reflect how the patient typically performs the task. So we need to use our clinical judgment. For example, if the patient's function is affected on a short-term basis due to an acute illness, so maybe they have the flu or a UTI, the scoring should reflect the patient's function when they are healthy. So the intent of the SCIM is to assess and show change in function. So if their function is compromised just by temporary health issues, then we want to score based on how they would typically perform. Other things to keep in mind when we talk about adaptive devices, this is equipment that is used to help the individual to complete the task. So this could be universal cuffs, sliding boards, wheelchairs, and assistance refers to the different levels of physical assistance that they might need. So I want to go through a few different case examples just to give some ideas about what that scoring would look like. Again, most of this is quite intuitive if we go through it, but it's nice to review some specific cases. So looking at respiration and sphincter management, this is a 64-year-old female, SCI C6, AISB. So patient has been breathing well during the day. She does not have a trach. She does not require cough assist and is able to clear secretions independently. She has been prescribed a CPAP to assist with respiration at night. She has used the CPAP a few nights, but is not tolerating the mask and is refusing to wear the device. So when we look at the options for scoring, it's from 0 to 10. And in this case, although the team has recommended the CPAP, because the patient is able to function without the CPAP, and that's what she's chosen to do, her score would be 10, so breathing independently without assistance or device. So in this case, looking at mobility for the room and toilet, this is a 35-year-old male, SCI T1, AISB. Patient is independent with wheelchair weight shifts and push-ups. He is independent with turning upper and lower body in bed using the bed rails. He's able to sit up in bed by elevating the head of the bed. So these are the scoring options in this case. And when we're looking at this mobility, there's 4 different areas. So turning upper body, turning lower body, sitting up in bed, and doing wheelchair push-ups. And in this case, this patient would score as a 4. So they're able to perform 3 of the activities independently. So elevating the head of the bed would mean that he's not doing that on his own. However, if we look then at doing our reassessment at time of discharge, we see that the patient is no longer elevating the head of the bed to sit up, but he does still use the bed rails. He occasionally grabs the side of his wheelchair to adjust his position in bed. So in this case, he would then score a 6 as independent. And so when we look through the SCIM toolkit, it gives some guidance in this area to say that assistance means that the patient can change their position in bed without physical assist or aid of an electric bed or power wheelchair. So they are able to use the bed rail, the side of the wheelchair, or an overhead strap or a bar. Looking again at another one for mobility. So transfers, bed and wheelchair. This is a 64-year-old male, SCI T10, AISA. While at the rehab hospital, this patient developed bilateral carpal tunnel syndrome. He underwent surgery for carpal tunnel release while at the hospital, resulting in a greater need for assistance with mobility and transfers. So prior to the surgery, he completed independent lateral transfers. He now needs one person assist with placing the transfer board for level surface transfers. Prognosis from the surgeon is that he will progress to maximum recovery of hand and wrist strength and independence with transfers in 4 to 6 weeks. How would you score? So this is one where it's very important to use your clinical judgment. In this case, which is this scenario, if we were to follow the advice of the surgeon, knowing that in 4 to 6 weeks, so maybe a few weeks after discharge, this patient would be back to the same level that they were prior to the carpal tunnel syndrome, then we know that we would score them as independent. And again, using clinical judgment, if you feel that in this case that this patient will have long-standing issues, that maybe they are more at their baseline, then you would score them as 1. Looking at mobility indoors and outdoors and on even surfaces. So a 21-year-old female, SCI T9, AISC. So patient is now walking in her hospital room and short distances indoors with bilateral AFOs, a reciprocal gait, and a four-wheeled walker. When walking longer distances to the treatment room, she needs a short break sitting on her walker. And how do you score? So there's quite a few options here. We really need to work our way through them all. In this case, she would have a score of 4. So she's able to walk with a walking frame or crutches. So the directions in the toolkit indicate that the patient should be scored on the walking aid they use rather than their gait pattern. So for example, if they step reciprocally but use a walker, they would be scored as a 4, not as a 5. If a patient uses a walker and a wheelchair, you still want to consider what they would typically use and what is safe. But in this case, we look at a 4. So in self-care section, looking at grooming. So this is washing your hands and face, brushing teeth, combing hair, shaving, applying makeup. This is a 20-year-old female, SCI C6 AISC. So she is able to propel her wheelchair into the bathroom and position herself in front of the sink. She's able to turn on the water to wash her hands and her face. She's able to brush her teeth using a universal cuff and electric toothbrush. She does need help with opening the toothpaste tube and putting on the cuff. So these are our options for scoring. And in this situation, she would require partial assistance. And the key part here is that the assistance is needed to don and doff of the universal cuff and needing assistance with toothpaste management. Looking at self-care, so bathing, upper body and lower body. This is a 44-year-old male, SCI C5 AISB. So patient needs a mechanical lift to transfer onto the commode. His caregiver positions his commode in the shower room and adjusts the water temperature. The caregiver passes the patient a soapy cloth and he's able to wash his face and chest. He needs help to wash his hair, wash and dry the remainder of his upper body and his complete lower body. So how would you score upper body? And how would you score lower body? And in this case, we're looking at he requires total assistance. And we can see reading through the scenario, he is able to do portions of the self-care, but it's very small part that he's able to complete on his own. And it's primarily the caregiver that's completing all the tasks. Respiration and sphincter measure. So a 33-year-old female, SCI C7 AISA. So patient prefers to complete bladder management in bed. She's able to transfer independently using her transfer board, wheelchair to bed. She requires one person assist with clothing management and pillow placement for positioning. She is independent with self-cathing and draining urine into a urinal. Residual urine volume are low, and she has some occasional incontinence during the day, and she typically wears a brief during the day and at night. Now, I find this one the more difficult to score, primarily because I'm an OT, and this isn't an area I think about very often, and usually our nurses do this component of measurement. But if you walk your way through all the scoring, you can see that where she is at is at a 9. So she's completing her self-cathing, and she is using external drainage instrument, and she uses the pads or brief. So that is considered the external drainage instrument in this case, but she does not need assistance for applying it. So going through, so she would score as an 11 if she was not incontinent, as she is, and she does not wear a brief. So again, it's just going through this one step by step. So there's a lot of resources, and I've put them on here that can help with this administration and scoring for the SCIM. There's also references that you can access as well if you want to look at some of the information about why this outcome measure was chosen, research projects that have been done with it, and maybe looking at some of the sensitivity or reliability and validity. So I'm going to pass this over to Jess, and she's going to look a little bit more at the use of the SCIM data, so how it's collected and how it can be used to inform practice at the program level.
Yeah, so now we're just going to look at how SCIM data is actually collected within Canada, within some of the rehabilitation centres within Canada. So just a little bit of background to RHSCIR and what is RHSCIR. I know we've spoken a little bit about it already in this presentation. But back in 2002, it was recognised that in order to create wider change for people living with SCI in Canada, it was important to start collecting national data, and the Canadian SCI registry was created, and this is the Rick Hansen SCI registry, or RHSCIR for short, and is actually overseen by Praxis. And we know that every spinal cord injury is unique, and one of the ways to study these many variations and complications and outcomes is through a registry. And without one, there is no way to know how to improve care or bring new therapies into practice. It's a way that we can track the incidence, so the number of spinal cord injuries within the centres that are collecting data, the cause, the severity and the outcomes, and how this might be changing over time. And really interestingly, it's a unique way to link researchers, clinicians and people with spinal cord injury to facilitate clinical research and then further support the integration of evidence and best practices into daily practice. So RHSCIR collects data across the care continuum. So it collects data such as demographics and medical history, as well as data from the time of injury through acute care into the rehab centre and into the community. And actually in 2020, RHSCIR 3.0 was launched, and we saw the addition of non-traumatic spinal cord injury data within the rehab setting. So now that is collected at rehab centres participating in RHSCIR across Canada. And it also collects outcome measure data from the time of injury, so we can see that in the kind of neurological data that we get on the acute side and the rehab side, but it also captures functional outcome measures as well, and that is actually the Spinal Cord Injury Independence Measure, and it's a way of measuring functional outcomes and changes for people living with SCI. So this is an example of how RHSCIR data can be used and how it's tracking changes over time. So for a spinal cord injury, a traumatic spinal cord injury from the 2004 time point to 2019, we can see trends in increasing age, with falls now being the primary cause of injury versus it previously being transport related. And there is many more incomplete cervical injuries, so there's higher up level injuries, but less severe injuries. So there's 30 acute and rehab centres participating in RHSCIR across Canada, and 10 of these rehab facilities are collecting SCIM clinically, and we can see the list there on the screen. And the one way that we are feeding this data, so the data collected by these facilities, one way we're feeding this data back to them so they can use it at a clinical level is the SCIM clinical reports. And they're site specific, and they're really used to be, they're really aimed at feeding this data back to teams to inform clinical practice or practice change. And they are sent out biannually, and we can use it to track implementation, and it offers comparisons to other sites collecting SCIM as well, so it provides a national average. And they can see how many patients are receiving this best practice at their facility on admission and discharge in comparison to other facilities as well. We also see we also provide data back on median SCIM change, both for the total SCIM score as well as the subdomains. And then we also look at the minimal clinically important difference, again, both for the total and subdomains. And importantly, we break down this data by neurological group in order to make the data meaningful so they can actually apply it to their patient population and patient groups. So now looking at a national level and the data at that higher level, we've collected a lot of data within RHSCIR since it's actually been implemented clinically in those rehab settings. So if we look from RHSCIR participants with a traumatic spinal cord injury discharge between January 1st, 2015 and September 2020, we've got a large number there, so we've got 3,635. We have to exclude those that didn't attend rehab because we're looking specifically at the rehab data collection point. And those that were admitted to rehab and then were discharged alive, we have 2,215. And then we need to know, did they have a SCIM on admission and a SCIM on discharge, as well as did they have that neurology? Because obviously that gives that context around what was their AIS and what was their neurological level, because that will impact their function. And then collectively, we have, with the clinician collected SCIM data, AIS and single neurological level on rehab admission and at discharge, we have 697 participants with all those data collection points. So actually quite a large pool of data that we could potentially look at to start informing clinical care at that kind of higher level. So we just wanted to provide some examples of possible clinical questions or research questions that could be answered using the SCIM data that we have. And one possible one would be, what would predictive length of stays look like based on the SCIM scores? Or how do SCIM scores change if a person returns to the community? And the real key part to this is thinking about how could this information impact care? What is the purpose of looking at the SCIM data in that way? What outcomes are we trying to achieve? And actually, by answering some questions related to SCIM, we could look at goal setting or focus on care planning. Is there certain areas for certain levels of injury that goal setting would be a key focus? Or could it really inform where discharge planning, is it a length of stays, and really guide client discussions around expected progress if we're looking at those SCIM scores as they change. So if you want to contact us about any information in this presentation, both our contact details are here, both for myself and Gwen. And we'd like to thank you for joining us during this presentation, and please reach out if you do have any questions.